RVI, but the plan is for all this to move across. And you will find there are some changes going on with the services all moving across to the RVI, but you'll be fully informed of where you need to go for tests if we send appointments out. And the reason we do this is predominantly to look for any evidence of a predisposition to epilepsy. That's the main reason why we do it. So we can also detect what we call encephalopathy, which is just a subtle dysfunction of the brain where it's not quite working as well as it should. Okay, and we can see that as well. This is a young lady having the EEG electrodes put on. Again, it measures. There's no electricity going the other way. It's completely painless. The only thing I would say is if you get the appointment, don't get your hair done the day before because they have to stick these on and it does make a little bit of a mess of your hairstyle. Okay. Another test that we sometimes do is an electromyogram or EMG and nerve conduction studies. These are usually done at the same sitting by the same doctor with the same machine and in the neurophysiology department again. The reason we do that is that the EMG looks mainly for whether there's evidence of muscle disease, okay? Whether there's evidence of an ongoing process that is making the muscles weak. The nerve conduction studies, as the title implies, is mainly to look at whether there is damage to the nerves, wear and tear on the nerve endings, okay? Sometimes that can be caused by something like diabetes. Sometimes it might be a direct response to the mitochondrial disease itself. And this is just showing how a little electrode is popped down at the hand and a tiny little electric shock is given at the elbow such that when that stimulates the nerve, the doctor can measure how long it takes to get down and then he can work out whether the nerve is functioning properly. The other things we do is that we can do brain scanning, okay, in a variety of different modes. The CT brain scan has been around as one of the longest tools that we have. It's still very, very helpful, and that will generally be done at the neuroradiology department at the RVI, although at the moment, for a little while longer, there is still the possibility of it being up at the Newcastle General. The advantages of CT scanning is that it can show abnormal calcium deposits in the brain, which is something that we see on a not infrequent basis in some patients with mitochondrial disease. It might also show whether there are old strokes or shrinkage of the brain in areas that might be affected and causing problems. That's the picture of a CT scanner, so it's kind of like a big donut. It doesn't usually bother too many people because it's quite open as you lie on that platform going in. The MRI brain scanner we use more and more these days. Again, same department. Very similar to a CT, but it can show much finer detail. It can even show you individual nerves coming out from the base of the brain, if that's what you need to look at. So we do use that more and more. The main thing about an MRI scanner is it's a magnetic resonance imager, so it uses very high strength magnets. And so anybody with ferrous metals, iron-containing metals, or electronic implants can't go in. Okay, this is something we ask about when we book them, and they double-check and treble-check. So it's not usually a problem, but it's something that sometimes you can't. If you have a pacemaker implanted, you can't have one. If you have a cochlear implant in place, you can't have one because of the dangers of that. And that's a picture of the MRI scanner, just sort of cut away so you can see exactly how that works. Some patients, because they're in there, feel a little bit claustrophobic. Okay, there tends to be a big clanking noise as it takes the pictures as well. However, the people who are doing the test, who put you in there, will generally give you earphones and then play you awful music from the 70s to put you off. Okay, so that can help to distract you. If you are called for an MRI scanner and you are claustrophobic, just tell them about it, okay? If you're a little bit claustrophobic, they'll generally calm you down and talk to you throughout it. Most people are fine. If you're very, very claustrophobic, occasionally we ask GPs to maybe give you just a little tablet beforehand to help calm the nerves occasionally. But actually, these scanners don't look so much like this these days. The newer scanners are getting thinner and look more like the CT scanner, so they're not quite such a big problem in that regard. And these are the sort of images we can get off an MRI scanner, okay? So if we do one of these scans, if we can pull it up on the system in clinic, we can sometimes show you this. And it's not often you get to see your own brain in this sort of detail. These are the eyes and the lenses you can see there at the front. That's the nose. The ears are here. This is actually the balance area of the brain, and what we call the brain stem down there. And here, cut the other way down, all right? What we can see is the balance area there and the brain here. Okay. The other test that I should mention that you might have, whether we should call it a test or not, is the Newcastle Mitochondrial Disease Scale, which many of you who attend clinic will know. I mention it because I know it's quite time-consuming, and I think, given the choice, many people would probably prefer not to go through all of these sort of questions. I would just stress that there is an importance to this test which probably isn't readily apparent at clinic, and probably that we don't often have a chance to explain in as much detail as we'd like. We do it at the clinic, but the importance of it is that not only does it help to make sure that we ask about all sorts of aspects of your condition which we might not otherwise think to ask about, whether it be whether there are problems with constipation, or whether there are problems doing normal day-to-day tasks in the bathroom, and these sort of things. But it's important for us to know that. But also, it very much helps to guide future research into mitochondrial disease and helps us to learn more and understand more. And it will help us as well in terms of therapies which we might trial in mitochondrial disease to detect whether there's actually been a true difference without treatment to following treatment as well. And we've been using these sort of measures in the patients that's been involved in the exercise trial as well. So whilst it can be a little bit tedious in clinic, if you can bear with us, we only aim to do it about once a year as a rule. It really is quite a helpful tool for us, and it's actually something that's been adopted sort of Europe-wide for that reason, so that people can learn more and understand more about mitochondrial disease, which will hopefully lead on to better treatments for it. I only put that up because all of these things are just tiny aspects to completing the puzzle of mitochondrial disease. We certainly aren't there yet, but we have made huge strides in understanding it over recent years. I think we still have a few more turns to go of the old Rubik's Cube there before we get all the colours on all the sides, but we are making progress, and very much with your help. And that's really the end of my talk. I'd just like to say thank you very much for listening, and any questions?
Okay, thank you very much, Andy. I think one of the things is that a lot of the time when you come up to the clinic, we do send you off different places. Andy, which kind of tests are we likely to do on a regular basis with patients, and why those particular tests?
Okay. For most patients coming along to the clinic, if we assume you're coming maybe on a 6-monthly or a yearly basis, then the things we would do commonly would be once per year the Newcastle Mitochondrial Disease Scale. Okay, so we will run through that, which involves a cognitive assessment whilst we're there in clinic. We will quite often do a blood test whilst you're there. I say a blood test because it's one needle and one syringe, but actually we send it off for a whole host of things, okay? But we'll never leave you anemic from the samples we take, but that can be very helpful. We will often do a heart trace, probably about once a year as a rule. Some people may need it more often, some people less, but that's something that's very easily done, and we will often do that. And we'll often do the spirometry as well. Not in all patients, because some patients we know they're at very little risk of that particular problem and their previous tests were fine, so we might let them off the hook. But for those patients who have muscle weakness as a rule, we'll often get them to blow into the machine just to make sure there's no weakness of the respiratory muscles. So those are really the main tests that we do regularly.
Just from everybody's perspective, those tests can actually alter treatment, can't they?
Yeah, and that's the reason we do them. Like I said,